Why are we even talking about dropless? Why not just keep using the 3 postoperative drops? There are real burdens on the staff and the surgeon time having to sit in that room and talk about using their eye drops. Who here loves making drop sheets? It brings me joy. Just kidding, it's horrible.
For me, it was a frustration with operational process in the clinic, patient frustration with the cost of drops, massive amounts of callbacks, staff dealing with explaining drops to people who have difficulty.
You know, I couldn't look at another sheet where somebody colored stenciled how they're going to use their 3 different drops. It was ruining the cataract experience. And I shifted from trying to do the best surgery I can to creating the best patient experience for my patients.
We're going to be talking about a new dropless regimen for cataract surgery that utilizes OMIDRIA as the cornerstone at allowing us to really kick away those post-op drops.
So a study that we did with Brian and Kathy McCabe was really the idea of showing, hey, is dropless as good in terms of non-inferior, in terms of inflammation, pain, and all the CME and all the things that we worry about with topical medication. The primary endpoint, no statistically significant difference at day 8 between the orange, which is dropless, and the gray, which is topical drops. And if you look at day 30, at a month out, patients were pretty much inflammation-free in both arms. If you look at a lot of the typical AEs we worry about on the left there, we don't see a statistically significant difference in terms of all those AEs. In terms of IOP, no significant difference there or at day 90. And at day 8, really very similar between the 2 groups. But the most important thing is the differences between topical and dropless were not seen. I really was one of those doctors who thought, I need the NSAID because of CME rates. And we're looking at change in macular thickness. So we looked at baseline OCTs, and then OCTs at 30 days and 90 days. No difference statistically between the 2 groups as well. So if you have this infusion in your irrigation solution that has NSAID on board, you're not letting that blood aqueous barrier get disrupted quite as much. So if you suppress it at the time of the surgery, then post-operatively, you're not having to deal with as much of that inflammatory cascade. It's like stop it from starting. We look here, the CME rates here, they're equal between the 2 groups, 1 in each group.
But we want to make sure that OMIDRIA is actually containing enough of that NSAID to hit the retina and target the tissue. So Eric Donenfeld did a study on this. He had 2 different situations, one in which it was just topical and then they took a aspirate to see how much ketorolac was in there, and then they had one with OMIDRIA. The mean vitreous ketorolac concentration in OMIDRIA was so much higher, 836 times. And this really provided me with the confidence to say that we are getting so much NSAID in that eye, not just in the anterior chamber, but getting it into the vitreous. And if we're trying to avoid CME, that's where it really matters.
In a stressful, busy practice, more than the time, which is absolutely the case, the happiness of your staff. My techs are less stressed out. It reduced the callbacks to the office by 50%. It makes a huge difference. Your staff will be happier, they'll be more in the game and less burdened by these different things.
So we actually asked patients to comment. We're like, hey, write down, how do you do it? How do you feel? What kind of a difference? Remember, these are patients where both eyes were done. So the same patient had experience with dropless, it was randomized, or topical drops. And these are fun ones. It was hard to remember to use the drops, and the drops were kind of irritating. My patient she came in and she was like, I hated those 3 bottles. Why'd you make me do that? And then in the orange is the aha moment where they had the dropless regimen. You can just see, it was like so much easier, much better.
The biggest surprise for me though was this effort was all for my staff and the patient experience, but I had no idea that patients would understand how valuable it was that we were offering a drop-free regimen. I thought it's their first time having cataract surgery, they wouldn't know any different, but they did. They spend a lot of time talking to their friends or social media. So there was a point 7 years ago, a year into it, almost 1 in 4 patients that were new came because they said, I heard you do drop-free surgery. But it was a big deal for our practice because we became labeled and identified as a drop-free practice, not just for patients, but the referring network as well. The optometrists were telling patients, oh, if you go there, you'll have a drop-free regimen as well.
Okay, here we are after the initial keratome incision, injecting some OMIDRIA from the bottle into the anterior chamber. Remember, it's phenylephrine and ketorolac. I think the ketorolac has some analgesic properties as well as the anti-inflammatory properties, which I think is beneficial early on in the case. Injecting some dispersive viscoelastic. Now, at the end of the case, when it's all completed, injecting some BSS into the anterior chamber, tapping that lens down. Now I'm going to take some preservative-free moxifloxacin, injecting about 0.2 cc's into the anterior chamber and hydrating the wound as well with the moxifloxacin. And the last thing I do at the end of the case is inject some steroid, which is triamcinolone. Here's a 30-gauge needle in the inferior nasal area through the subconj, bevel up, and going about 2 millimeters into the subconj space, injecting about 0.15 cc's of Kenalog 40 or about 0.4 cc's of Kenalog 10.
OMIDRIA is a cornerstone of dropless therapy because we're able to quell the inflammation right from the source. With a dropless regimen, we have happier patients, happier staff, and a happier experience for us as providers as well. A reminder that OMIDRIA is the only FDA-approved intracameral NSAID. And as we saw with the Donnenfeld study, that is a highly effective way to get a lot of NSAID right into the vitreous to hit the tissues where it matters.